This is an 82-year-old male complaining of hemoptysis and dyspnea. So on his history, end-stage renal disease. He's on dialysis Monday, Wednesday, and Friday, and he comes over from, or you're called to dialysis because he has this hemoptysis and dyspnea that he's developed during the treatment. They kind of got him through the treatment, and towards the end of the treatment, they called 911. He's got a history of a cough, and he's been coughing up blood streaked. Whoops, I missed an O. Streaked sputum. He reports he's got night chills and sweats, but no fever, no chest pain, but he has dyspnea on exertion, DOE, dyspnea on exertion. States he feels like crap. He substituted a different word than that, but he feels like crap. On exam, he looks tired. He's unwell. A little bit older than his stated age of 82. Skin is warm and flushed. And he's just sitting there in the dialysis chair, just kind of like a wet noodle. Lung sounds, scattered wheezes, and bronchi. Let's see, that's mainly in the left lower lung field, but he's got some wheezes throughout. His respiration's non-labored. Cap refill is 4 seconds. Normal cap refill is less than 2. He's up at 4, so he's got poor perfusion. His extremities are mottled. Another marker for poor perfusion. Let's see, his blood pressure is 70/38. This is a gentleman who's not usually hypotensive after dialysis. Some of our dialysis patients are, and that's normal for them. His pulse rate is 130. He's breathing at 24. His oxygen saturation is 89% on room air. Temperature is 100.4, so he has a fever. So what other assessments are indicated? So he's hypotensive. He's a dialysis patient. Sounds like he's got some dyspnea. So other assessments, capnography, may help differentiate that. We already talked about that. I'm going to write end-tidal CO2 and abbreviate that. 12 lead EKG may be indicated. Yes, he's not having any chest pain, but he's got some chronic medical issues. He's hypotensive. Very reasonable to do to kind of help try to figure out why we're hypotensive. I'm going to bring up the point of care ultrasound because that might be somewhat helpful with him in terms of differentiating what's going on in the lungs. And then some places again are doing point of care testing, for example, of point of care lactate. This gentleman he's hypoxic, he's febrile, he's tachycardic, and he's hypotensive. Skin is warm and flushed. He kind of looks a little septic to me. So point of care lactate may be helpful to kind of help determine that the extent of his poor perfusion. What's our I'm sorry, that's under evaluation. What's our assessment? What may be going on? Probably the number one thought is pneumonia. He's got the lung sounds, he's got the fever, he's got the hypoxemia, so that makes sense. This could be a bronchitis where there's bronchospasm. We didn't get into whether he was a former smoker or not. Does he have a COPD history? COPD exacerbation is also on the list. Could this be acute coronary syndrome? Well, most of the time your STEMIs and non-STEMIs don't come with a fever, so I'm gonna say probably not, unless he's having EKG changes because he's hypotensive. That's a little bit different issue, and that can happen, but that may be the case there. His story does not sound like PE. What about CHF? That may be a possibility there too. He's a dialysis patient. A lot of times those patients are on fluid restrictions. A lot of times the dialysis may be inadequate, especially if they start getting running into issues at the end of dialysis. So that's still a possibility. However, again, CHF doesn't usually come with a fever, so I'm guessing that's probably not. So treatment priorities. This is a guy that probably supplemental oxygen is going to be helpful. He's going to need some IV fluids, and I know he just went through dialysis. I know he just had some fluid taken off, but he's hypotensive. He's looking septic. I wouldn't necessarily flood him with a huge volume of fluids, but in titrated doses would be very helpful to support the blood pressure and help protect his perfusion. We need to get his perfusion up to try to improve his perfusion there. He does have some wheezes, so perhaps a trial of a neb treatment to see if that improves the oxygenation. That may be something that's helpful. Now, as I mentioned, he appears to be septic. There are some EMS services that are administering antibiotics in the field. This is not commonplace yet, but especially with the movement to treat sepsis early, this may be something that you'll see some services do. So in terms of reevaluation, we're going to follow vitals. We're going to follow end-tidal. We're going to auscultate and reassess the patient. And then disposition. The patient doesn't have any specialty needs. They're in some distress. They've got sepsis, but he's not having a STEMI. He's not having any other kind of specialized stuff that going on that would mandate bypassing the local hospital. I guess the only consideration, if he's stable enough, he's got a history of end-stage renal disease. He's going to need a place that can do dialysis in the hospital. Now, this may or may not be a consideration in your area. If you're working in a relatively rural area where it's a prolonged transport time to the next hospital, then we need to get this gentleman stabilized and figure out what's going on, so the closest hospital is appropriate. But if you're working in an area where it's known that a certain hospital perhaps does not have a dialysis bed, dialysis unit, or they're full, and again, this is looking at the whole system-wide, then it may be prudent to bring the patient to a hospital that can do dialysis. Again, that's system-dependent, and that may vary depending upon where you are.